It is Sunday evening in late August, peak respiratory syncytial virus season, and a 4-month-old Aboriginal girl named Ruby is carried into the StAMPSville emergency department by her mother and grandmother.
3 days of runny nose and cough, and tonight she is feeding poorly and working hard to breathe. Give me the numbers you want first.
Temperature, 37.9. Heart rate, 168. Respiratory rate, 66. Oxygen saturation, 87% in air, persistent over 10 minutes. Marked subcostal and intercostal recession, tracheal tug, nasal flaring, and diffuse fine crackles with wheeze right across both chest fields.
And the background that changes everything?
Born at 35 plus 5 weeks, so late preterm. Mother smokes. Breastfeeding is winding down. There is a 20-month-old sibling at home, and her mother did not receive the respiratory syncytial virus vaccine in pregnancy. Weight today, 5.4 kilograms.
82 days to the exam, foundation phase, and this is the pediatric respiratory episode. Today we grade severity, we nail the oxygen thresholds, we recite the do not list, and we work out when a remote hospital escalates and retrieves.
Bronchiolitis first as a definition, because everything flows from it. A viral upper respiratory prodrome, 1 to 3 days of coryza, followed by lower respiratory signs in an infant under 12 months. Distress, diffuse crackles, wheeze. It is a clinical diagnosis.
Say that again for the marking scheme. Clinical. What does that make of your investigation plan tonight?
It makes it empty, and that is deliberate. The 2025 Australasian Bronchiolitis Guideline is explicit. No routine chest x-ray, no routine viral PCR driving management, no bloods unless you suspect sepsis or the child escalates, no biomarker predicts deterioration reliably.
In a town with point-of-care biochem, blood gas, hemoglobin and INR sitting on the shelf, the discipline is not using them.
Exactly. The tests exist, the diagnosis does not need them. The examiner is listening for you to say that out loud.
Walk me through severity grading then, because every disposition decision hangs off it.
3 grades, 5 domains: behavior, respiratory rate, accessory muscle use, oxygen saturation, feeding. Mild is a normal behaving infant, rate under 50, nil to mild recession, saturations above 95% persistently, feeding adequately.
Numbers, not adjectives. Moderate.
Moderate is some irritability, rate 50 to 69, moderate recession with tracheal tug and nasal flaring, saturations 90 to 94% persistently, and feeding below half of usual volume. Severe is the step change, increasing lethargy, rate 70 or more, marked recession, saturations persistently below 90, or hypoxemia, the low flow oxygen cannot correct, an inability to take more than 20% of normal feeds, or apnea.
Where does Ruby sit on that table? At 6:40 in the evening.
Moderate to severe, her rate is 66, her saturations are 87%, her recession is marked, and her feeds are a third of usual. Any one of those alone might sit moderate. The stack of them, on day 3 of illness with 3 risk factors, is severe.
Before thresholds, the risk factors. The guideline treats them as continuous and cumulative. Name them the way the marking scheme wants.
Gestation under 37 weeks, and Ruby qualifies at 35 plus 5. Younger chronological age, under 10 weeks carries particular risk. Prenatal or postnatal tobacco smoke, and her mother smokes. Reduced breastfeeding exposure, faltering growth, comorbidities, congenital heart disease, chronic lung disease, chronic neurological conditions, congenital diaphragmatic hernia, trisomy 21, indigenous infant, economic disadvantage, and the timing and severity of illness at presentation.
The guideline says something careful about indigenous infants that a fellowship candidate should be able to reproduce. What is it?
That indigenous status in itself is unlikely to confer biological risk. The correlation with severe outcomes persist independent of socioeconomic status, and the guideline names why. The ongoing impacts of colonization, remote geographical isolation, and institutional racism in our health systems.
And what does that understanding change in your clinical behavior tonight in practical terms?
It lowers my threshold for admission, and lengthens my observation for an indigenous infant with risk factors, and it makes me arrange follow-up with a named owner rather than a generic instruction. It is an equity action, not a stereotype. Ruby's family get the same facts, the same respect, and a lower discharge bar, because the data says that is where the risk sits.
Before the oxygen, the imposters. 4 conditions walk into your department wearing bronchiolitis clothes. Name them and give each one its tell.
Bacterial pneumonia, focal crackles, a toxic infant, fever above 39, foreign body, sudden onset after a choking episode, asymmetric chest signs, and a history nobody volunteers until you ask. Pertussis, paroxysmal cough with color change in a partially immunized infant, and congestive cardiac failure, the quiet one, sweating with every feed, faltering growth, hepatomegaly, a gallop where the wheeze should be.
2 bedside discriminators that cost nothing and separate all 4.
Symmetry of the chest findings, and the growth chart. Bronchiolitis is diffuse and symmetrical, and except for the acutely ill infant, the weight tracks, focal or asymmetric signs, or a baby falling off its curve over weeks, and the costume drops.
And the 5th imposter specific to this district, chlamydia.
Chlamydia trachomatis pneumonitis, afebrile, under 3 months, staccato cough, conjunctivitis in the history, and a mother whose own screening needs a diplomatic revisit. It is the one that changes the family conversation, not just the baby's chart.
Oxygen. The 2025 update refined the thresholds, and examiners love the split. Give it to me exactly.
Supplemental oxygen, when saturations are persistently below 90% for an infant 6 weeks or older who is otherwise healthy, persistently below 92% for an infant under 6 weeks or under 12 months with an underlying health condition. Those are starting thresholds and stopping thresholds both.
Ruby is 4 months, so the 90% line applies. 2 words in that rule carry the marks though.
Persistently and alone. Persistently means brief desaturations during sleep do not count. Do not start oxygen for them. And oxygen is not given for work of breathing alone. If the saturation sits above the threshold, however hard the ribs are working, oxygen Oxygen is not the treatment.
87% over 10 minutes at rest is not a brief sleep dip.
It is not. She starts low-flow nasal prong oxygen, titrated to hold her at or above 90, and I aim for the minimum oxygen that does it. The guideline is also explicit that chasing mid-90s is unnecessary. Titrate down. Trial off every 6 hours, and once she has been stable in air for 2 hours, the continuous monitoring stops.
Monitoring that wraps around that oxygen order. What does the night actually look like on paper?
Continuous oximetry, because she is hypoxanemic and on oxygen, and now apnea alarm coverage as well. Respiratory rate counted for a full 60 seconds, not glanced at, hourly at first, heart rate, behavior, and a pediatric early warning score trend that anyone walking past can read. The trend is the instrument. A single set of numbers is a photograph of a moving thing.
And the observation discipline that protects the rest of the ward.
Cluster the cares. 1 look, 1 listen, 1 feed assessment, 1 wait, then leave her be. Every handle is a desaturation, and every desaturation we manufacture ourselves is noise on a night when I need signal.
So far, you have ordered one thing. Now the negative list, and I want it strong, because candidates lose marks here every single sitting.
No beta-2 agonists. Not in any infant under 12 months with bronchiolitis. Not even with a family history of atopy. Outside a trial. Strong recommendation.
Corticosteroids.
No systemic or inhaled glucocorticoids. Strong recommendation. The only carve-out is severe disease requiring intensive care, where combined corticosteroid and nebulized adrenaline may be considered, and that is a pediatric intensive care decision on the phone, not a ward routine.
Antibiotics. And here is the trap, because Ruby is an indigenous infant and people reach for the prescription pad.
The guideline anticipates exactly that. Do not routinely use antibiotics, including in infants at higher risk of bronchiectasis, indigenous infants, adenovirus, socioeconomic disadvantage. That is a weak recommendation, but the direction is clear. Antibiotics only if there is a genuine bacterial focus or sepsis.
Hypertonic saline. Chest physiotherapy. Suction.
No routine nebulized hypertonic saline. No chest physiotherapy. No deep nasal suction. Superficial suction of the nose only if upper airway secretions are blocking feeding, which is comfort care, not treatment of the bronchioles.
That is the strongest answer a StAMPS candidate can give in bronchiolitis. What do you actually do all night then for the infant you have admitted?
The things that work are humble, oxygen to threshold, feeding support, minimal handling, because infants desaturate when you disturb them, so cluster your cares and leave her on her mother's chest. Continuous oximetry only where it is indicated, and here it is because of what happens at 3 in the morning.
Take me there. The clock says 0300.
The monitor alarms. Ruby stops breathing for 15 seconds, desaturates to 78, drops her heart rate briefly, then restarts on her own. It happens again twice in the next hour, shorter, but it keeps happening.
Define apnea for me precisely.
Absence of breathing beyond 15 seconds, often with bradycardia or desaturation. In bronchiolitis it is a marker of severe disease. It can be the presenting feature in young and preterm infants, and it converts the plan.
Converts it to what?
Continuous monitoring with an apnea alarm, which she already has, and escalation. Recurrent apnea in bronchiolitis strengthens the case for transfer. She is now a severe infant on the table even if her saturations have behaved since the oxygen went on.
And the feeding question, which in a 4-month-old is a severity question in disguise. Half of usual. Why that number?
The guideline sets the floor at half of usual intake with at least half of usual wet nappies. Above that, oral feeding continues. Below it, or when feeding is unsafe, choking and exhausting at the breast, the nasogastric tube goes in. Expressed breast milk first, small frequent feeds or continuous. Intravenous fluids only if the gut is not an option or transfer is anticipated, and then strict maintenance, because overhydration has its own harms.
Ruby has been taking a third of usual volume and coughing at the breast.
So she meets the nasogastric criterion on admission. That is a decision I make in the first hour, not after a bad night. Weigh her, chart every feed, chart every nappy, and put the numbers on the observation chart so the trend is visible to whoever takes over.
Expressed breast milk, or formula, and why does the distinction matter at 3 in the morning?
Expressed breast milk first, because mom can express at the bedside, it protects her supply and her role when everything else about tonight has been taken out of her hands, and the gut tolerates it better. Formula is the fallback, mixed feeding already being her reality, small frequent boluses, or a continuous drip if bolus is reflux, and the volume prescribed, so the night nurse is not improvising.
The weaning of that tube is itself a discharge criterion.
It is. The tube comes out when she feeds half of usual or better by mouth, safely, over a sustained period, and the discharge assessment watches the feed, not just the saturation.
One more number before we go further. The natural history, day of illness, and the window that worries you after presentation.
Peak severity sits at day 3 to 5 of the illness. Ruby is day 3, so she is entering her worst window now, and the guideline emphasizes most deteriorations happen within 48 hours after presentation, which is why timing of presentation relative to the illness is a discharge criterion in itself.
Day 3, 48-hour deterioration window, 3 risk factors. Saturation, 87, apnoeic by 3 in the morning. You said the plan converts, so here is my question, and it is the question the whole night has been building towards.
Ask it.
You have one high-flow device in a hospital with no pediatric intensive care, an aircraft 90 minutes away that takes 3 hours to actually arrive, and a baby now apnoeic on your ward. What exactly do you do in the next 30 minutes?
First the oxygen, because everything else waits on it. She has been on low flow since 6:40 and her saturations hold at 92-93, but her respiratory rate has not come down and her recession has not eased.
4 to 5 hours on low flow with no improvement in rate, heart rate, or early warning score. That is the definition of low flow failure in this guideline. What does failure earn her?
Escalation of respiratory support, and in parallel, the phone call. The two happen together, not in sequence.
Name the call.
PIPER. Pediatric Infant Perinatal Emergency Retrieval, the Victorian Service 24-hour line, 1300-137-650. A consultant answers, and I make the referral in ISVAR format: identity, situation, background, assessment with the severity grade and the trend, and my request.
And your request is what exactly? Say it the way you would say it on that phone.
I have a 4-month-old late preterm Aboriginal infant, day 3 of bronchiolitis, initially moderate to severe, now with recurrent apnea and low flow failure. I have a single humidified high flow device and infant circuits. I can nurse her 1-to-1 tonight, but I cannot nurse her 1-to-1 for 3 days. I need a decision on high flow now, a destination, and a time you can be on the ground.
That is the referral. Now the device question, and be careful because this is where rural credibility is won or lost.
High flow sits after low flow failure in the flowchart, and it is not routine first line for moderate disease. She has failed the low flow trial and she has apneas, so high flow is defensible, but I start it with PIPER on the line, at their starting settings, with their monitoring expectations because they own the consequence of the decision.
If the high flow had not been available or the infant circuit was missing, what then?
Then the conversation is earlier and blunter. Low flow continued, apnea alarm on, and a recommendation to retrieve on that basis alone, because an infant I cannot support is an infant I need gone upward, safely, tonight.
The aircraft. 90 minutes of flight from a base 900 kilometers away. What does that number actually mean for your night?
Activation, crew, flight, and handover make it closer to 3 hours from my call to their boots on my floor, so the interim plan is not a holding pattern, it is active management with named jobs.
Delegate it. You have no resident medical officers. Who does what while the clock runs?
Nurse 1 stays 1-to-1 with Ruby, on the monitor, titrating oxygen to the threshold, charting feeds and nappies hourly. Nurse 2 is pulled from the ward to cover the emergency department and to prep transfer paperwork, which thins the ward, so I phone the ward coordinator and name the trade-off out loud before it bites. The Aboriginal health worker supports mom and grandmother, arranges care for the 20-month-old sibling, and starts the conversations I will need later. I do the referral, the notes, and the family explanation.
And the 3 hours themselves. The aircraft is coming, but the baby is still yours. Active management means what, concretely?
A warm room on an August night, because cold infants work harder to breathe. Skin to skin with mom whenever the monitoring allows, because a calm baby breathes better and a frightened one does not. The resuscitation trolley checked and the bag mask sized and at the bedside, because if she tires further I will not be hunting for equipment, and if her work rises or the apnoea is lengthened on high flow, the next step is positive pressure by bag and mask, 2 people, and the general practitioner anesthetist woken at home before I need her, not after.
Escalation inside an escalation. Does PIPER know that plan?
I hear it in the same call, because the plan I run overnight is the plan we agreed together. Nothing that happens in this building at 4 in the morning should surprise the consultant holding the other end of the phone.
Document the do not list in the notes. Why?
Because writing that salbutamol was considered and withheld, that steroids were considered and withheld, per the Australasian guideline, is both good medicine and the exact sentence the coroner or the examiner wants to find. Silence reads as omission, explicit reads as reasoning.
3 in the morning, she is on high flow, the aircraft is coming, mom is frightened and the grandmother has not spoken since the alarm went off. Walk me through that conversation without jargon.
We sit, we do not stand. I use plain words. Ruby's lungs have a virus that makes babies tire, and the machine is doing some of the breathing so she does not have to. The aeroplane doctors are coming to take over her care in a bigger hospital, and mom travels with her. I ask the grandmother what she has seen tonight that worries her most, because she has been watching this baby longer than the monitor has.
And she tells you the baby did not feed like this with the first 2 children, ever.
And she has given me the severity history in 1 sentence, and I say so out loud, in front of the family. Family knowledge is clinical data in this town. The health worker makes sure the questions we still need answered are asked in the way this family answers questions, and that our answers land the way this family hears them.
Consent for transfer and the sibling in the corridor with her own risk profile. Deal with both.
Consent from mum, documented, with teach back. She says the plan back to me in her own words, and the sibling is not a footnote. She is 20 months old, Aboriginal, in the age band where the Victorian Nurse of VMOP program covers her. She can be immunized before this family leaves the building, and I book it before I finish the transfer notes.
Hold the sibling there, because we come back to that at discharge. The retrieval team lands. What do they need from you in 30 seconds?
ISVAR again, tight. 4-month-old late preterm Aboriginal girl, day 3 bronchiolitis, presented moderate to severe, low flow failure and recurrent apnea overnight, now on high flow at these settings. Saturations this, rate this, feeds by tube at this volume, weights and trends on this chart, no drugs given, none indicated. The negative list travels with the patient.
And the destination question you asked PIPER to decide. Regional Pediatric Unit 295 kilometers by road or pediatric intensive care by air. Who decides and on what basis?
PIPER decides, and the basis is support need. An infant on high flow with apnea trends toward intensive care, but August fog or a front over the ranges can ground the aircraft, and a stabilized infant on low flow oxygen may reach the regional unit by road before a grounded plane could ever fly. That contingency is PIPER's arithmetic, not mine, and I say so. My job is to keep her stable enough that both options stay open.
Now the counterfactual, because StAMPS gives you the quiet version of the night too. Same baby, same risk factors, but saturations 93 in air all evening. Feeding half of usual, no apnea. Discharge or admit?
Admit, or observe for longer than my instinct says. She stacks 3 risk factors on day 3, entering the peak severity window, with a 48-hour deterioration risk after presentation. The guideline could not be clearer that risk factors lower the bar for observation and admission, even when the infant looks mild on arrival.
And if you had sent her home at 10 that evening, saturations 93, feeding half, what would the written criteria for that discharge have needed?
Clinically stable with mild to moderate effort. If she had needed oxygen, a 3 to 4 hour observation off it in air, including a period of sleep, holding 90 or above. Feeds at half of usual or better with half of usual wet nappies. days, parents confident, with written deterioration advice, a social situation that allows home, which at midnight with no transport does not, and local follow-up arranged by name, which in this district the next morning clinic owns.
A sleep period is the detail most candidates skip. Why does it matter?
Because saturations dip in sleep, and an infant who holds her numbers asleep is the one whose airway and drive are genuinely coping. Discharging on awake numbers alone is grading the baby on her best hour.
And what if she had been watching from home, never brought in? What does the discharge packet look like for the baby who goes home tonight, mild and safe?
Written, numeric, and named. Return immediately for apnea or color change, feeds below half, breathing that gets worse, ribs sucking harder, lethargy difficult to rouse, fever above 39, a 24-hour phone contact that a human answers, a named local review inside 48 hours, booked before the family leaves, with a named owner, not a slogan.
Now the immunization piece, and I want the Victorian detail, because this is the highest yield prevention mark in the episode.
The Victorian Respiratory Syncytial Virus Mother and Infant Protection Program runs mid-March to the end of September 2026. Nirsevimab, the long-acting monoclonal antibody, brand Beyfortus. Ruby qualifies because her mother did not receive the maternal vaccine, and Ruby is under 8 months. Her sibling qualifies because she is an Aboriginal child aged 8 months to under 24 months.
Doses. By weight.
Under 5 kilograms, 50 milligrams intramuscularly, 5 kilograms and over, 100 milligrams. Ruby weighs 5.4, so 100 milligrams into the anterolateral thigh, single dose, before or at discharge, documented in the Australian Immunisation Register. Adverse events reported to SAEFSE.
And for the next pregnancy in this family, the maternal side.
Abrysvo, the maternal vaccine, 28 to 36 weeks gestation, on the national program year-round now, and it needs to be given at least 2 weeks before birth to protect the baby. That conversation happens once, kindly, while the memory of this night is fresh.
Before we close the pediatric file, the differentials that scare me in a 4-month-old at 3 in the morning. 2 of them.
Sepsis and meningitis, the toxic, lethargic, poorly perfused infant that bronchiolitis can masquerade as or sit alongside. And foreign body, the sudden onset asymmetric chest, a choking episode in the history that nobody mentioned until you ask directly.
And the cardiac one that hides in plain sight.
Congestive cardiac failure from a congenital heart lesion, sweating with feeds, faltering growth, hepatomegaly, a gallop, a baby who has been quietly failing for weeks and tonight looks like bronchiolitis with extra cracks.
Now retrieval of memory, spaced repetition, because this podcast is a memory system as well as a clinical one. 7 days ago, we did the pregnant woman with a headache at 32 weeks, first number in that room.
168 over 112, severe hypertension, an obstetric emergency, treat before you investigate.
The drug ladder, 1 line.
Labetalol 20 to 40 milligrams, intravenously every 10 to 15 minutes, maximum 80 per dose, or hydralazine, 5 to 10 every 20 minutes, or oral nifedipine, 10 to 20 every 30 minutes, target under 160 over 110.
Magnesium.
4 grams over 20 minutes, then 1 gram per hour for 24 hours, with calcium gluconate, 1 gram in 10 milliliters, physically at the bedside.
The line that ends that case.
The only cure is birth, and StAMPSville does not birth, so the call to retrieval is made at the moment of diagnosis, in parallel with the treatment.
Yesterday, the young woman with lower abdominal pain. The test that comes before everything.
Urine pregnancy test on every woman of reproductive age with abdominal pain. Pain out of proportion to bleeding, ectopic until proven otherwise.
And the unstable one, with free fluid on the bedside probe.
Theater and retrieval activated together, because the aircraft is 90 minutes away and she may not have 90 minutes.
And the regime she would have had, if it were pelvic inflammatory disease instead. 1 breath.
Ceftriaxone 500 milligrams intramuscularly, plus doxycycline 100 twice daily, and metronidazole 400 twice daily, both for 14 days. Partner treated the same day, retest at 3 months. All booked before she leaves the department.
Severe features in the hypertensive pregnant woman, the ones that force the magnesium decision. Rapid fire.
Headache that will not settle, visual spots, epigastric pain, hyperreflexia with clonus, saturations falling, platelets falling, and a rising creatinine, any one of them beside a high pressure, and the infusion starts.
The examiner lens, 60-40, answers over style. What does a passing bronchiolitis answer sound like in this town?
It opens with the grade, because grading is the decision. It states the oxygen threshold with the 6-week split. It recites the do not list without being asked. It feeds the baby by tube and says so. It names PIPER 1300137650. At the moment severity declares itself, not after.
And the fellowship answer goes further. Say the last sentence of that answer.
In a town that cannot nurse this infant for 3 days, transfer is not an escalation of failure, it is the treatment plan. And the family, the siblings' immunization, and the mother's smoking conversation all travel with it.
3 things to say tomorrow.
1. Supplemental oxygen at persistently under 90% for infants 6 weeks and older, under 92 under 6 weeks, or with comorbidity, never for work of breathing alone. 2. The do not list is the marking scheme. No salbutamol under 12 months, no steroids, no routine antibiotics, and written down as decisions, not omissions. 3. Escalation is PIPER at the moment severity declares itself, with high flow only after low flow failure, and a named nurse, a named health worker, and a numeric safety net carrying the infant both directions.
82 days out. Tomorrow, stroke in a town without a scanner. Sleep on the thresholds, because tomorrow the clock is 40 fewer minutes than you think.
Until tomorrow, keep the grades honest and the lists negative. It is the discipline that keeps babies off ventilators and candidates on pass marks.